Okay, actually I was not planning for these slides, but some of students came to me and Tariq, they said we do not understand some blood vessels or some other concepts. So me and Tariq, we decided to start with this and then I can show you some of them. Okay, so let's see them. Bismillah. These are, most of them you have seen in the lab, in the lecture, but I have modified some new pictures. Okay, like this. This is a very, okay, well, this is a very basic slide to show you the various arrangements, number one, and then you should know foregut, midgut, hindgut, where is it. So this is esophagus, after that we have stomach. This is duodenum. Only this part, this C shape is duodenum. After duodenum, we'll make a flexure. I told you. The flexure is duodenojejunal flexure. No valve. Alatul, it will shift into duodenum, ila jejunum. Then, from jejunum, we will have ileum. This is jejunum. So this part is jejunum. If I make a roughly a small abdomen, so this part is mostly jejunum. Mostly. This part is mostly ileum, because they are coed. Then we have an ileocecal junction. This has a valve, ileocecal valve. This has a valve. And the guarding is by autonomic nervous system plus some hormonal control. I don't know, physio people will tell you. Then the food from here will go to cecum. So here is cecum, here is appendix, then here is ascending colon. This is near the liver, so we call this as hepatic flexure or right colic flexure. Then this is spleen. So here splenic flexure, or we call this as splenic or left colonic flexure or left colic flexure, still same. Okay, colonic or colic flexure, no problem. Then we have descending colon, and then we have sigmoid colon, and then we have rectum, anal canal, and anus. This is just an overview. Where is the foregut? Duodenum has 4 parts. C-shaped duodenum, we have a C-shaped duodenum. Let me move this. Okay, we have C-shaped duodenum. This is the first part, 2 inches roughly. Then we have this vertical part, this is D2, all D2. Then we have D3, and then we have a elevating or superior sort of, or we call D4. And here we have duodenojejunal flexure. Okay. Of course, here we have the ligament of Treats to hold it and to regulate the movements, but without valve, no valve. It's only the ligament of Treats which controls the movement. Okay. Now, in the middle of the D2 here, we have roughly here, this level. This is a demarcation of foregut. After that, from D2, so all jejunum, all the ileum, all ascending, cecum, ascending, appendix, all here till this junction. What is this junction? 2/3 here, 1/3 here. This is demarcation for midgut. After that, we have hindgut. The artery for this part is celiac trunk. It has multiple branches for liver, even gallbladder, pancreas. Then we have 2 big arteries, superior mesenteric artery in this direction, inferior mesenteric artery in this direction, arising from aorta. For example, think of aorta behind this structure. Okay, here we have superior mesenteric artery in this direction. Here we have inferior mesenteric artery in this direction. This will give multiple branches, mainly 3 big. Here we have 2 big branches. They will divide into multiple branches. They will make a marginal artery of Drummond, anastomosing with these branches, and this is how the blood supply of the gut is there. I will give you the names of the branches, everything. This is just an overview to make a comprehensive impression on you. Okay. In the C-shaped concavity of duodenum, we have head of pancreas. Here, this is duodenum. Here we have head of pancreas. After the head, we have neck. Then we have a body of pancreas, and then we have tail of the pancreas. This is how it is. And you know this makes the stomach bed. You know this already. Okay. The next slide is, because these ducts are a part of GI tract. GI tract is composed of tubal part of the gut, that is intestine, small, large, cecum, blah blah blah, and it has big glands like liver, like pancreas, like gallbladder. Gallbladder is not a gland; it's a reservoir, store. It's a store. So liver is basically how the secretions from liver reach the GI tract. This is the pathway. So we have two lobes of liver, right and left. They have multiple small ducts. They will make one big duct, right hepatic duct. On the left lobe, left hepatic duct. Both of them they combine here, and they make common bile duct, or sorry, common hepatic. Right hepatic, left hepatic, they will make common hepatic. Common hepatic will join the duct of the gallbladder, cystic duct, to make common bile duct, or clinically we can say bile duct, no problem. Then it will come behind the duodenum and it will enter at this ampulla.
So which
We are-
part?
The second part, D2, second part of duodenum. Inside, if I cut this part, I have another picture to show you. If I cut this part, how you will find the entry point. Why these ducts are important? For example, here is the opening of this duct. Actually, here we have, okay. Before opening into D2, it will combine with the duct of the pancreas. So, bile secretion, bile will produced here, come here, store here. When we eat fatty food, it will contract, it will make secretions here into the second part of duodenum. Plus, when we eat proteins, the secretion, the proteolytic enzymes from the pancreatic secretion will reach the same duct. So, at this region, two ducts are like same. Here is the bile duct, here is the pancreatic duct. Both of them they combine, and then they open in the second part of duodenum. Okay? This is controlled with a sphincter of ODI, sphincter of ODI. I will show you further pictures, and this is just an overview to understand many things in this lecture. Are you clear?
Yes.
Okay. Okay. This is duodenum. You can find various pictures, various relations. Here, for example, this is the first part. I told you the first inch and the second inch are specific. It's so you can remember from pictures, or you have to remember them, the relations. So what is above here, what is below here, what is behind, what is anterior, posterior. Similarly, D2, D3, D4. This is what you have to do. Here it looks like, so this is the point where we have the entry of the common bile duct. Okay. Here is the one. If I cut the duodenum, you will see this structure and this structures. This is known as major duodenal papilla. Major. This is known as minor duodenal papilla. Why major? Why minor? Major is the one where we have both the big ducts, common bile duct, pancreatic duct open. In the pancreas, if you see the pancreas, you will see head, neck, body and tail. The main pancreatic duct is this one. It is combining with bile duct opening here at the major duodenal papilla. I will show you papilla, wait. But head part of the pancreas has an extra duct. This is known as accessory duct of pancreas. This makes duodenal papilla minor papilla. So, we should remember the distance from the oral cavity or mouth to the papilla. How? So, major duodenal papilla. Okay, what is papilla? Papilla is an elevation. So, this is duodenum. Here we have an elevation. Avalan. Then we have ampulla, which is an opening. Okay? So, papilla is just an elevation, and at the tip we have an opening which is known as ampulla. So, junction of foregut and midgut, this is one of the clinical importance, plus 8 to 10 centimeter distal to pylorus. Why this distancing is important? Because when you are making gastroscopy or duodenoscopy, you should remember the distance, how deep I have gone now. The major is around 8 to 10 and minor, you see minor is before that, proximal to it. So minor is roughly 6 to 8 centimeter distal. Major is for opening of bile duct and pancreatic duct both. The minor is for accessory pancreatic duct only. Okay. Another use of this is there is a procedure known as ERCP, endoscopic retrograde cholangiopancreaticograph. Or suppose here is the gallbladder, there was a stone. It unfortunately slipped into bile duct and the stone is fixed here now. What it will cause? A condition known as obstructive jaundice. Because the bile will go into the liver, stasis will cause infection, it will cause obstructive jaundice. If I want to remove or if I want to diagnose this condition, I must enter from GI tract. Yani, the scope, it should enter into my stomach, then it should go my duodenum, it will enter here. At this point, I will inject a dye, I will see what is happening here. So, endoscopic retrograde, yani in a reverse fashion, cholangio of this duct and gallbladder, pancreato of this duct and pancreasgraphy. So this can be done. Now, with new advanced techniques, we can even reach here and we can remove the stone. So this is happening. This can happen. If this fails, we have to open. Because obstructive jaundice is not as bad. If the stone is here, this is bad or this is bad. Or here the stone is bad.
Yeah, last one.
Last one is of course the worst because it's obstructing too. If it is here, we may delay some time. But if it is here, it's very dangerous. Why? Because it's going to stop the pancreatic secretions. So pancreatic secretions are being produced, but they are not being utilized. It will accuse acute severe pancreatitis and necrosis and everything because they are proteolytic enzyme. The body is protein itself. So it will have very fresh proteins available every time and it will start it. This is a very bad situation for pancreatitis. Am I clear for these points?
Doctor, on the obstructive pancreas, don't we have another opening for the minor obstructive?
It is usually draining only the head part. The main secretions are coming from the body and tail. Okay, so that is the reason. Just other.
Yeah, how it forms stone?
The stone is not formed here. The stone is formed in the gallbladder.
But it slips.
Stone is formed in the gallbladder. See this picture. Okay. Sorry. See, this is the gallbladder, saphra. If we have metabolic disorder, here the stones are formed. Then, if they are big stones, it's good to have big stones, they will not be able to pass. If they are very small stone and multiple, they can pass of this duct. This is the reason. In the ducts, we don't have stone formation. Stone formation actually occurs in the gallbladder. I hope that I answered your question.
Thank you.
Because the movement isn't precise, how it moves.
Secretion. If this is if I have a pipe, even if it does not have a peristalsis, if I put water, it will go there. So it's simple. The transport. Okay. Now this is clear, ampulla, because this was lacking in your lecture, so I bring it. Many of you came with peritoneum folds and recesses. Take a general concept. This is a part of duodenum. Okay? Some parts are retroperitoneal, for example, in whole of GI tract, let us say. Some parts are retroperitoneal. Some parts, they are attached like these folds to the posterior abdominal wall or some other structures. When they are attached like this, we have some potential space below them. So here is the attachment and here is a potential space. These potential spaces are known as recesses. Okay? I told you potential space, you can't see my pocket if it is not full. Once it is full, you can see it. So it means there was a potential space. Now it is filled. So whenever it is filled, we have chances of collections, or another part of intestine, if moving aggressively, fix here. It will be known as herniation and it can give you strangulation. What is strangulation? This is a part of, okay, let's see here. This is a part of any intestine, small, large, any intestine. It has blood vessels here entering into it. If this becomes like and fixes in small area, this area will constrict, decreasing blood supply and causing ischemia. And the part which is fixed will become necrosed. This is known as strangulation. Strangulation is killing the person like. So this is known as arterial strangulation. Or if this can become twisted, or some part of intestine can go into itself. How? Itself is like this. This is a normal intestine. If, like especially these cases are seen in Ramadan, the intestines are empty for 8 hours. Then in 8 minutes you want to eat everything in the world. So what will happen? So this part will be obstructed. This is known as intestinoption. But these are pathological terms, so don't waste your time here. Let's see the herniation here. This is a part of intestine, for example, D3 or D4. Here we have attachment and here we have a potential space. All such potential space are known as recesses. So we have duodenal recesses, which are important to us. We have superior duodenal recess, like behind there is a fold in the upper part. So superior duodenal fold, we have superior duodenal recess. Like inferior duodenal recess, like paraduodenal on the side, and like retroduodenal on the back, on the behind the duodenum. We can have recesses. For cecum, we also have such recesses. But that is not your objective. Only just remember one point. The retrocecal recess is very important because in normal 74-75% of the people, appendix is present in this recess. I will show you appendix. Okay. Now we have a concept of internal herniation and strangulation. What is external hernia? Inguinal hernia, for example. This is the inguinal region. The muscle was weak here. A loop of intestine comes below the skin, behind the skin. So this is herniation. Leaving apart, leaving its normal position and slipping out. This is in external herniation. Like for example, here in the umbilicus, if we have a weak umbilical abdominal muscles, intestine can protrude out. So this is umbilical hernia. Similarly, in these recesses, for example, this is the recess part of the duodenum. Any other part of intestine which was hypermobile for some time, it slipped inside and stuck. Now this is internal herniation. This can cause you gangrene, this can cause you strangulation, this can cause you intestinal obstructions. Initially obstructions and then other symptoms. Clear? Okay, this is the concept for same. If I make GI tract lie on a road, it is 7 meters long, okay? So 7.5 meters. We have 6 meters of small intestine. We have 1.5 meters of large intestine. Okay, so roughly 7.5 meters is the total. This is just to show you aorta. I just expanded aorta, giving you celiac trunk, and celiac trunk is for up till this level, foregut. From foregut, you see superior mesenteric artery supplying duodenum, jejunum, ileum, cecum, blah, 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 everything up till this point, which is the midgut, and from here onwards is the hindgut. Here we have inferior mesenteric artery supplying this part. So I just expand to show you the conceptual way of distribution of blood. Celiac artery is like this. Here is abdominal aorta, This is very conceptual figure. Here is celiac trunk. Celiac trunk will give you, you know this from the blood supply of stomach. Left gastric splenic artery. Here we have spleen. Splenic artery. Then here it will give you common hepatic. Common hepatic will divide into right gastric and hepatic proper. Hepatic proper will divide into right and left hepatic. And right hepatic will give you cystic. Cystic for gallbladder. So this is how celiac trunk is doing. Regarding the duodenum, we have here a gastroduodenal artery, which will give you here superior pancreaticoduodenal artery and right gastroepiploid. So no problem. This is not our task today. We are interested in gastroduodenal and superior pancreaticoduodenal artery. How they look like here? You have done this in stomach. Let's see for the duodenum only. So here is gastroduodenal artery. It will give you superior pancreaticoduodenal. Because this celiac trunk is supplying foregut. The foregut is finishing here. Understand?
Yes.
So we should have an artery from midgut, superior mesenteric artery. It will give you inferior pancreaticoduodenal. Of course, they will anastomose inside or outside, and this completes the blood supply from two sources of superior, yani foregut and midgut, celiac trunk and superior mesenteric with their branches. Am I clear at this point?
Yes.
You have question? This is how we have anastomosis between two big vessels of foregut and midgut. This is the point. Okay. Superior mesenteric artery. I told you it is in this direction. This is aorta, this is superior mesenteric artery. This is duodenum. In front of duodenum, it's crossing. This is the main trunk of superior duodenal artery, superior mesenteric artery. There are three main branches: ileocolic, the last one, the right colic, this one, the middle colic, this one. How I remember? MRI scan. Okay. Don't tell anyone. Don't write an exam. So it has three branches: MRI, middle colic, right colic, ileocolic. Ileocolic will of course give branches to cecum and appendix. This will have branches in this region, and ultimately what will happen? Let's see the inferior mesenteric artery. Here is the origin. So it is in this direction. This is celiac trunk. It's very small. Here branches. This is superior mesenteric in this direction. Let's see inferior mesenteric. It's like in this direction. It has only two big branches. One for sigmoid, so sigmoidal arteries. One here we have right colic artery. Here we have left colic artery. So MRI, middle, right, and inferior are ileocolic, and here we have left colic. Now see the branches of both arteries. This will give you multiple branches. Of course, the superior mesenteric will give you multiple branches here. Duodenal, jejunal branches for all duodenum, jejunum here. Let's combine both of them. Now here is the combination.
Okay.
Good? Understanding? Here is the aorta, here is superior mesenteric artery. So, MRI, three branches. Then, they will anastomose with each other. And this anastomosis will make me a artery of Drummond or marginal artery. Here we have sigmoidal branches. Here we have left colic. They also anastomose and make a marginal artery. And then this point and this point at this middle junction will also anastomose. So there is an anastomosis between superior mesenteric branches and inferior mesenteric branches to complete this marginal artery, which will then supply to the GI tract. Am I okay?
Yes.
If there is a blockage here, we are safe because there are multiple branches, blood supply will go. Until I have a very big blockage here, or if I have a big, small blockages here. So these are going to cause intestinal gangrene, ischemia and gangrene. Am I clear?
Yes.
Okay. This is just to show you how portal vein is formed. This line you should remember till even after Yom Al-Qiyamah. Even after. Superior mesenteric vein. Here is spleen. Here is the splenic vein. Here we have superior mesenteric vein. Here we have inferior mesenteric vein. So this is superior mesenteric vein, inferior mesenteric vein. Both of them, they join here and they make a portal vein, which will go into the liver. So liver is having two blood supplies, arterial and venous. Arterial from hepatic artery. You know celiac trunk, common hepatic, right hepatic, left hepatic. So arterial supply. There is a mixing of blood in the liver between arterial and venous blood, because venous blood is also going there. This will be done by physiology people, how it is separated, blah blah blah. I don't know anything. Okay. Now inferior mesenteric has many options. There are, for example, inferior mesenteric vein can join splenic vein. Classically, this is usually the happening. Or it can join here in the junction. Variations. Or sometime, rarely, it can join here in the superior mesenteric. But the classical is like this. We can have some variations. So no problem. If there are variations, still no problem. The drainage is good. But ideally, classically, superior mesenteric vein joins with the splenic vein to form portal vein. Yeah.
Could you please repeat the inferior mesenteric artery branches?
This is inferior mesenteric artery, two big branches. Like here we have three big branches from right, superior mesenteric, here two big branches. And then they will give you multiple branches. One is sigmoidal arteries. One is left colic. They will give you anterior, posterior branches, multiple branches, and they will anastomose. We don't need there in detail. Okay? How they anastomose is like this in this picture. Okay, mesentery. Who will tell where is the mesentery of small intestine?
Before that, can you point to the root of the mesentery?
Where? In my body?
No, the picture.
Yes, of course, I am coming. Where is the root of, what is mesentery? Mesentery is a two-layer fold of peritoneum attached on the back of my abdominal wall. It has a free border here, covering the loops of intestine. So, this is intestine. Here is my root of mesentery. It will come, cover it like this and go back. So all the duodenum, jejunum, the last part of duodenum, jejunum and ileum, all is in this free border. It looks like a fan. Here is the Japanese fan to help you. This is the attached margin. This is the free margin. Where is the attached margin? Here is the attached margin on the posterior abdominal wall. Here is the attached margin on the posterior abdominal wall. This is posterior abdominal wall. You see vertebra. So here is posterior abdominal wall, attached margin. You see two layers, loop and come back. This is how it is. On a side view, on a very front view, you can see like this. This attached margin, this is free margin covering the loop of gut. Now, where this is attached? On the posterior abdominal wall, the long free edge is foreintestine. The short root is continuous with the parietal peritoneum on the posterior along a line. This is the attachment. Extend downward and to the right from the left side of L2 vertebra to the region of right sacroiliac joint. So this is the line. Here we have L2 vertebra. So here is L2 level. This is the line of joining of intestine, mesentery of small intestine. Here we have right sacroiliac joint. So this is the direction. In my lecture, you remember this picture?
Generations.
Yes. But now, see this colored picture to make your life less miserable. Like here is that point, attachment. What are the structures it's crossing? Aorta, inferior vena cava, muscle, quadratus lumborum. So here is the attachment of your mesentery for small intestine. Jejunum and ileum mainly. You know the contents and everything from the theory.
Yes.
Okay. Take another view of the mesentery. Where is the attachment? This is posterior abdominal wall. So here are the attachments.
Yes.
Here are the loops of jejunum and ileum. So this is the attached part. This is the free part. This is the attached part. This is the free part holding various loops. On a cut side, you will appear like this. But remember, all of them, they have two layers. Because it's a two-layered structure. Understand? Good. McBurney's point is very clear to you.
Yes.
Before McConkie, you didn't mention where is the root.
For what?
For the mesentery.
When I didn't mention? In the lecture? No, I mentioned, I showed you this picture. This black and white picture.
So where is the root exactly?
On the posterior abdominal wall, starting from roughly level of L2 vertebra, going oblique towards the right, near the right sacroiliac joint. This is the attachment. On the attachment, it is crossing various structures. What are the structures? These are the structures. Now clear?
Doctor, on the level 2 on mid-clavicular line.
L2, not here, L.
This is on the mid-clavicular
Number 2, huh? Yes. Yes, here is roughly L2 and here is the mid-clavicular line. Okay? L2 mid-clavicular, because you shifted L here.
Yes, yes, I was pointing to my
Mid-clavicular line. Huh. Okay. Okay. It's clear?
Yes.
McBurney's point is clear to you.
Yes.
Anterior superior iliac spine, umbilicus, make a line of takhayyul, imaginary line, divide into 2/3, 1/3. Here is the McBurney's point. What is the structure down here?
Base of the appendix.
Base of the appendix, not the tip, because the tip may be 2 inches or 10 centimeters long, so it can be shifted.
Position.
It can have various positions. I will show you positions now in the system. Cecum, we have, what is the surface anatomy of cecum? Here we have inguinal ligament. On the lateral half we have, make one line, another line here in the same mid-clavicular line, and a third line here, intertubercular line. This triangle is responsible for obtaining my cecum, whereas ileocecal junction at the junction of these two lines, mid-clavicular and intertubercular. This is to show you certain mesenteries and the associated gutters. So right paracolic gutter is here on side of the colon, both the sides. Left colic gutter is here on both the sides. What is this?
This is the mesentery.
This is the root of mesentery. Here, from here it will come, cover the loops of jejunum and ileum, and go back attached. So this is mid-clavicular line here. This is sacroiliac joint. So this is the attachment of mesentery. Where? On the posterior abdominal wall. And of course it will cross aorta, inferior vena cava, quadratus lumborum, and other. Here is another mesentery. I told you, inverted V-shaped mesentery of transverse mesocolon. You remember? I will show you more pictures. This one. Sorry. So sigmoid mesocolon, the mesentery of mesocolon or pelvic mesocolon, sometimes they say. I write in the lecture, she writes better. Triangular fold of peritoneum which suspends the sigmoid mesocolon from the pelvic wall. How it is formed, how it is attached. Here we have an inverted V-shaped structure here.
Yes. I think so. Why?
Here, this is aorta, this is common iliac, this is external iliac, this is internal iliac. Good? So, after, at the level of internal iliac, initial phase, and here till first, second, 3 pieces of sacrum, S1, S2, S3. This is the attachment of what? Attachment of sigmoid mesocolon. Of course, it is 2-layered. It will cover the sigmoid part of the colon. like to allow its mobility. I told you two important things. Any structure which is retroperitoneal means behind the peritoneum, it is fixed.
Yes.
All those structures which have meso or mesentery or like mesocolon or mesentery, they are mobile structures.
Yes.
And that is a gift that between the two layers we have blood vessels, lymphatics going to the structure, veins coming back. This is, we have the attachment of sigmoid mesocolon. Okay, here we have transverse mesocolon. Where is transverse mesocolon?
Below the stomach.
Here is the pancreas, retroperitoneal structure, very fixed. Here is the duodenum, some part of duodenum which is again retroperitoneal. From pancreas till it comes and covers the transverse colon and give you two layers. This is how we have transverse mesocolon. Attach where?
To the head of pancreas.
To the head of pancreas and body of pancreas, like this. Understand it? Khalas. If still you have any questions? This is your SDL. But before we jump on to the models, try to remember these points. For example, in this area, I won't be able to find this is duodenum wala ileum.
Yes.
So I should depend on these characteristics. Think of one thing of them and you can exclude the other.
Why?
Like for example, duodenum.
Should be proximal.
The best thing is to find the numerous circular mucosal folds. Where are the mucosal folds? If I should see inside. If the mucosal folds are very numerous, yani a lot of, then it is duodenum. If they are free and at spaces, this is ileum. This is a very big difference. Another, sometimes you need to see the blood vessels. If one arcade or maximum two arcades, that is duodenum. If we have more than other arcades, 3 or even more, then it is ileum. So these are very big. I will show you now. Okay? I finish here the theoretical part. I hope these slides were useful for you to give a good memorization or conceptual areas. And now we can see the models, the plastic and both plastic. Okay? Welcome.